So you guys have already talked about steroid-based hormones, right? Which ones have you talked about?
Cholesterol,
Cholesterol, yeah,
Pregnenolone.
aldosterone,
yeah, aldosterone, cortisol,
Yes.
are thyroid hormones? No, they're not. I know cholesterol, backbone for all of them. And there's all these different ones, aldosterone, cortisol, all of these ones. And we're going to talk about the sex hormones in specific, but they're also steroid-based hormones. The ones we're going to talk about are progestogens, estrogens, and androgens. Progestogens, we're going to talk specifically about progesterone, which is the major physiological progestogen, as well as synthetic ones that we make and use as drugs. So we have agonists, antagonists, and we also have a different type of pharmacological ligand called a selective receptor modulator that you may not have heard of, but we'll talk about how those work. We're going to talk about estrogens. Estradiol is the major physiological one. And then we have synthetic estrogens we use as well. We have synthetic agonists and we have synthetic estrogen receptor modulators. In addition to ligands, we also have synthesis blockers. And androgens are all of the male hormones. That includes testosterone, DHT, and synthetic androgens. And we usually, when we talk about male sex hormones, we talk about testosterone, and we don't also specify DHT, but is also connected to testosterone and is just as important as a male sex hormone. And then we also have synthesis blockers. So we've got a lot of different drug types that we're going to talk about. But I think it's important to see that those are how they're all related to each other. And then we'll talk about physiologically how they're related. So one of the things to start with is just to define that difference between sex and gender. And sex is that biological, it's genetic, it has to do with anatomy. That's what we call male, female. Physiological sex is not all or nothing. There's a lot of biological issues that can cause intersex anatomy. You can have things like someone who's XY who has androgen receptor insensitivity. So they're a fetus, they don't have testosterone receptors, or those receptors aren't super active. They're not going to develop male anatomy. They're going to develop a female anatomy because fetally, everybody starts with female anatomy, and then it's only if the androgens come in that male anatomy starts. So if you don't have receptor sensitivity to those androgens, you're not going to develop male anatomy. It's going to be female. We've also got, depending on the ratio and percentages of fetal hormones, different amounts of male versus female anatomy. And so when it's not completely binary, male or female anatomy, we call that intersex. And then we even have different chromosomal types. We have not only XX and XY, but we also have XXY. So there is a lot of variability just within the definition of sex. Then we have the gender definition, which is social. And so that is usually referred to instead of male, female as man or masculine, woman or feminine. And there's a whole range of people's gender identities. And there's probably an entire discussion that you could have to kind of explain those things if people are not clear and want to know more about those. There's a lot of resources. I should be saying male, female in some situations and man or woman in others. I will mess it up because they're just not in common language really used separately, even though scientifically and medically they are. So I'm going to try not to mess it up, but I will sometimes. And what we're going to be focusing on, because this is biological, pharmacology is anatomy, receptors, hormones, what we're going to be talking about is going to be the physiology and pharmacology. So that's when we refer to things, we're going to be referring to them in the context of sex and not gender, unless we talk about that specifically. Alrighty. Hypothalamic pituitary axis, your favorite thing. Do you love your HPA? You do. Someone does. Everyone's like, what? I want to go over it in a really basic way, even though I know you have had it. So I'm not doing this thinking you haven't had it. I'm doing it thinking you've had it so many times, it becomes even more confusing. I want you to see that the HP axis is the exact same, whether you're talking about thyroid, cortisol, estrogen, it is no different. It's the exact same thing. And so if you learn the axis, you just plug in the hormone and you don't have to memorize 5 different axes. So what we're always going to start with is our hypothalamus. That's always going to release a hormone, call it hormone A. That hormone's always going to go to the pituitary. The pituitary is always going to release another hormone, hormone B. That goes in the bloodstream for sure. Has to go into the bloodstream. That then floats around, hits every single cell in your body, goes into every single cell in your body if it's a steroid hormone, but doesn't find the right receptor in every cell. So only some cells are going to have the right receptor for that. And those are going to be our first or primary target tissues. They're the only ones with that receptor for hormone B. So we get in here and that target tissue is going to do a few different things, but the most important one is it's going to create and produce the final hormone, hormone C. That one goes also into the bloodstream and it goes to all the secondary target tissues. And those are the ones that we are like, when we look at that, we're like, this is the effect of thyroid. This is the effect of cortisol. This is the effect of progesterone. We're talking about the effects on what the secondary tissues are doing. And then we're always, at every single step, going to have feedback inhibition. So hormone B is going to feedback and inhibit the hypothalamus and pituitary. Hormone C is going to go back and inhibit the hypothalamus and pituitary. So everything here that you release is going to feedback inhibit. So if you know this pathway and all you think about is here's the hypothalamus, it releases hormone A, that goes to the pituitary, which releases hormone B, that goes to our primary tissue, releases hormone C, that goes to our target tissue. That's the big effect we see. That right? And then everything goes back for inhibition. So let's look at hypothalamus pituitary gonadal axis, the HPG. And the cool thing about the HPG is not only is it the same as the cortisol and thyroid and everything in how you do the axis, but it is the same for estrogen and progesterone and androgens. Every hormone here is the same except for the last hormone and target tissues. So we start with the hypothalamus. It makes GnRH. That goes to the pituitary. That releases either LH, luteinizing hormone, or FSH, follicle stimulating hormone. It's going to release either one. So this one is just different in that it has 2 different hormones it could release. And it generally bobbles, in females, it bobbles back and forth. It'll release more LH at one time of the month, it'll release more FSH at another. That goes to our primary tissue, which is going to be the ovary. So the ovary is going to have receptors for LH and receptors for FSH. And then the ovary is going to release that last hormone C, which could be either estrogen or progesterone. That hormone C is then going to act at the secondary target tissues, which are going to be lots of different things. But we have neurological effects, we have effects on the skin, we have effects on secondary sex characteristics. Anything the estrogen or progesterone affects, that's our secondary tissue. The cool thing is the body decided to use the exact same pathway for males and females. It was like, yeah, that works. Why change it? So we have the hypothalamus releases GnRH onto the pituitary. The pituitary releases LH or FSH. The only difference in the male and female with LH and FSH is in males, you generally release them both at the same time, whereas in females, you alternate depending on the time of the month. So in the male, again, we have release LH and FSH at the same time. That goes now to the testes. That's what our primary target tissue. The testes make testosterone, the main hormone C, and then that goes to those secondary target tissues. which are secondary sex characteristics, again, neurological effects, characteristics on muscle, characteristics on bone development. So anything that is sex specific, that's that secondary target tissue. So again, for females, you go hypothalamus, GnRH, to pituitary, alternate LH or FSH, to ovary, decides whether to make estrogen or progesterone, to the sex tissues. Always feedback, negative feedback. And in males, hypothalamus, GnRH to pituitary, which makes both LH and FSH. Those hit two different testes cells, but I'm not going to have you know which testes cells are doing what. You just need to know at the testes, it's going to cause testosterone release and it's going to cause spermatogenesis, which we'll talk about in the lecture right after this. So for this slide, it's just going to testosterone, and then that testosterone is going to those secondary last tissues, which are the androgen sensitive cells, which are going to be the muscle, body, hair, bone, things like that. So does this look good? Okay, male and female, exactly the same. Awesome. Okay, so you guys already came in knowing that these are steroid backbone. So they're all structurally related. When we look here and we see testosterone and estradiol, which is that most common natural estrogen, and progesterone, and then compare it to something like aldosterone, which is not a sex hormone, it's pretty similar, right? And so when we talk about pharmacology, and Dr. Spiritu talked about receptor binding, lock and key, everything binds to one receptor. And then we said, but that's actually not true. Things receptor binding's not 100% selective. If that ligand looks enough like some other things, it might bind to two different receptor types. And so what we're going to see is these look so similar to each other that there's a lot of cross binding. That means like a progesterone might look enough like testosterone that it'll bind to both receptors. And so what we're going to see is you might have a progesterone that also has aldosterone activity or testosterone activity. So when we talk about these and we're talking about specific drugs that we've made, we may even be noting, oh, here's this drug, this one hormone, but it also has a little testosterone activity, or it also has a little estrogen activity. And that ends up mattering a lot, because if you're going to be picking birth control or menopause therapies or therapies for testosterone insufficiencies, you're going to have side effects on the other sex hormones. And so you're kind of picking and choosing, well, which one of these drugs is going to give you what you want. So learning why, which ones of these hormones and hormonal drugs have what kind of profile is part of what you're doing when you're picking these drugs. So these are all going to be structurally related. There's also going to be some cross-binding. The 4 hormones that we're going to talk about are going to be the estrogens, the progesterones, and the androgens, which include testosterone and DHT. So we have 4 major hormones. We have 3 major receptors. So our estrogen receptor, our progesterone receptor, and then we have 1 receptor for these, which is the androgen receptor. And so both testosterone and DHT are going to bind to the same receptor. They're going to do different things depending on which one's bound to it. So in some cells, it's going to be testosterone binding to the androgen receptor, going to do one thing, and other cells, it's going to be DHT binding to the androgen receptor. It's actually going to do something different because that same receptor is there, but it has a little different conformation based on what bound it. Technically, hormones have to be systemic. So when we talk about estrogen, it's got a systemic circulation. Progesterone does, testosterone does. DHT has low systemic, it's higher inside the cells it's made. It's really supposed to work within the cell that makes it. So there's argument about whether to call it a hormone just based on how much of it goes in your circulation. I'm gonna call it a hormone because it acts at the same receptor testosterone does. All right, so what's happening with sex hormones? Most steroid hormones have some action as growth modulators. And I don't know if you guys talked about that. When we look at sex hormones specifically, one of the major points of them is whether they make a cell grow and divide. And so when you think about what does estrogen do or what does testosterone do, they create sexual differentiation in tissues. So is estrogen going to go into cells that would become breast cells and make them grow and proliferate? And does testosterone go into cells that would become penile tissue and make it grow and differentiate? So, I mean, when you look at these, the most important thing about sex hormones is what tissues does it make grow? We're going to see that happening, that sexual differentiation happening in utero. That's when you first see the genital differentiation, and is why, like with receptor and sensitivities, you may not see genital differentiation. This also goes super high during puberty. That's when you get the secondary sex characteristics. Primary sexual characteristics are the genitals. Secondary sexual characteristics are what happens when you hit puberty. And then you have a lower amount of sex hormones through adulthood, which continues to then decrease until it gets pretty low when you're older. So it's great to have sexual differentiation to your cells. For any of that sexual differentiation you need anatomically, physiologically, you're going to need this growth from the sex hormones. When you don't want to increase cell growth is when you have cancer. So when we talk about there's a lot of prostate cancer, there's a lot of breast cancer, there's a lot of endometrial cancer. We think about those cancers that have to do with sex organs. If you have these tissues and you know that estrogen makes breast tissue grow faster and replicate faster, then if you have an estrogen sensitive breast cancer, estrogen's just gonna make it grow faster. Same thing with testosterone and some prostate cancers. So, but when we do talk about menopause therapy, we talk about cancer risks. Sex hormones do not cause cancer, but they can make it grow faster. Because cancers, I know you haven't had cancer yet, but you may have talked a little bit about it in foundations. Really is just when you have that cell cycle and you start knocking out the things that would be the brakes on the cell cycle. And those are mutations that knock out the brakes. You can knock out the brakes, but if there's no signal telling that cell to really ramp up, that mutated cell might just sit there for years and years and years. These will come in, and if that's a breast cell or a prostate cell, this will tell it to ramp up because it's saying grow faster. So those are really the things that when you're modulating growth, you are going to look at how you can have growth promoters and how that is involved in sexual differentiation. Growth promoters may speed up some cancer, but you also have sex hormones that are growth inhibitors. And progesterone is a growth inhibitor, so it can sometimes balance out estrogen. Estrogen might be making some tissues grow more, while progesterone would make them grow less. So we're seeing the androgens are promoters at the male sex hormones and tissues, estrogen promoters at ovarian, endometrium, breast, skin, vasculature, and a lot more. And progestogens are generally inhibitors at the things that estrogens are promoters at. All right, so if you gave estrogen only, gave progestins only, or gave both combined, what would happen at the ovary and what would happen at the endometrium? So take a quick second to think about that. Okay, estrogens only. What does that do at the ovary and endometrium? Promotes growth?
Yes.
Right. So if you gave just estrogen, you might have promotion of growth at the ovary and endometrium. If you gave progestin only, what would happen? Have decreased growth. Now, if you give them together, you're not gonna have much effect. That's gonna stay like where you were to begin with. All right, so these are steroid hormones. Tell me if you've seen this too many times, but we talked about them being growth promoters, or growth inhibitors. The way they inhibit or promote growth is that steroid hormone is lipophilic. It's gonna go into the cell, goes into every cell in your body. Only cells that have the right receptor are gonna act. So it's gonna go in the hormone goes in the cell, binds with the steroid receptor. If that receptor's there, the whole complex moves to the nucleus. It's going to bind a promoter region on a particular gene. And then it's gonna cause that gene to be transcribed and whatever protein and function comes out after that. So that's like technically how this receptor works. And you're gonna change the function of the cell that way. But that's how it acts as a promoter or inhibitor, is by changing which genes are going to be produced into proteins. That's how it's gonna change the growth. All this slide is to kind of make it clear how that relationship, how progesterones, testosterones, and estrogens are so closely related structurally, and that they're related to other things like cortisol and aldosterone, which is why you can have that cross binding. Here is the steroid hormone synthesis pathway that we're going to work with. When you look at something like this, in reality, physiologically, everything can go and be turned into everything else because things can be modulated through different pathways. This is the pathway we're talking about. So we're gonna have that common steroid precursor, cholesterol. That's gonna start it all. You're gonna make that into pregnenolone. The ones that you are gonna learn are going to be enzymes that are circled in green, the blue hormones, and these are also, so the enzymes in green and the blue hormones. So you're starting with cholesterol, you're making pregnenolone. That can, in many cases, go straight to progesterone. That progesterone is going to have its own activities. That progesterone can then, through CYP17, go on to androstenedione. Or if you want to get to here a different way, you can go through a CYP17 first and then into androstenedione. So the point here of this step is any way you want to go to pregnenolone into testosterone, DHT, and estradiol, you've got to have a CYP17, whichever way you're going to go. So you've got the pregnenolone, a lot of it will be made into progesterone and move on. Regardless of it, you've got to have a CYP17 to keep going. That then gets turned into testosterone. And then if it goes into a cell, because remember, these are all lipophilic, all going to go into the cells. If it goes into a cell that has the enzyme 5-alpha reductase, you're going to turn that testosterone into DHT. If it goes into a cell that has aromatase, it's going to make that testosterone into estradiol. When you look at it, testosterone, DHT, and estradiol are almost the same thing. I mean, they're super close to each other. The only thing that changes them is which enzyme you have there. Is it making it into DHT? Is it making it into estradiol? Or is it leaving it testosterone? And all that matters is what cell it's in. So the testes have the highest concentration of 5-alpha reductase. So the testes are going to make the most DHT. Aromatase is highest in the ovaries. They're the ones that have the highest amount of aromatase. So ovaries are going to make the most estradiol. You're going to have testosterone for both males and females because you can't get DHT or estrogen without testosterone. All of these enzymes are expressed to some degree in males and females. Guys are going to have some estrogen, women are going to have testosterone. I don't know how much DHT most women would have, but you're going to have estrogen and testosterone for everybody. We're just talking about a balance is what the body's going to respond to. That's where I'm saying both enzymes are expressed, at least in some concentration. And I can see that this is kind of a confusing looking sentence here, but what it's trying to say is there are different concentrations are made by different gonads, but they're both being made. The other thing is that aromatase and 5-alpha reductase aren't just in gonads. They can be in other tissues as well. So the adrenal gland also can make testosterone. Fat tissue can also make estrogen. It has aromatase enzyme in it. One of the things you might see is that people who have a high fat ratio can make extra estrogen. So I always say that estrogen is also made in adipose tissue. So say sometimes you might see in puberty a boy who's slightly overweight. Now the testosterone levels go up a lot for puberty. They're slightly overweight, so they've got some aromatase. They may start making estrogen as well. And that's how you see sometimes boys get swelling in the breast area when they're in puberty. And that's estrogen they're making. And that's going to be more likely if someone's slightly overweight because they just got more fat tissue. All right. So this will not surprise you then that these enzymes are all drug targets. So if you take a drug that's a CYP17 inhibitor, then it's going to stop everything here. You may make progesterone, but you're not going to make androgens or estradiol. And we have a drug that does that. The drug is in italics, which means you're not memorizing this drug for my lecture. What if you want progesterone, but maybe you have a prostate enlargement? And so you are fine with testosterone, but you really want to not have as much DHT. Then you could go and you could just inhibit the 5-alpha reductase. That would leave you with testosterone, but it would block DHT. Or if you want to be able to make your progesterone, but you just don't want to make estradiol, you can use an aromatase inhibitor to just block estradiol synthesis. So it's kind of neat. You can keep progesterone, but block synthesis of testosterone, DHT, and estrogen. Or you can keep testosterone and progesterone and block it from either going to estrogen or DHT. So it's nice because we do have some nice targets to be a little finessey about what we're going to block. Because most people don't want to get rid of everything. I mean, you could theoretically block everything, but you wouldn't want to. So this allows us to say, which are we going to keep? Which are we not going to keep? The way that I remember aromatase is the estradiol one is really stupid, but because girls smell good, which is dumb, but it helps me remember it. At least their stuff has perfume in it. That smells like something, even though I don't think it smelled good. Yes, this is the last slide for this. So I'm just going to do this slide and then we'll be great. So you know agonists, you know antagonists. You know the agonists occupy a receptor, activate it. You know antagonists occupy the receptor. I almost said octopi. So you have antagonists are going to occupy the receptor. They don't do anything to the receptor. They just keep agonists from binding. So no activation. And you know that we had partial agonists, which bind and some percentage of the time activate it, some percentage of the time don't. So those were the 3 ligand types that we talked about. And remember, ligands are anything that bind the receptor. So it could be, so progesterone itself naturally is an endogenous ligand. A progestin that we make in the lab is a ligand. So sometimes when I say ligand, people think, oh, we're talking about the drug, but that's not true. It's anything that's acting there. So we know about agonists, antagonists, partial agonists. Selective receptor modulators are a whole different thing. The selective receptor modulator is the ligand. So it's a drug. And when it goes to one tissue, it might have an agonist effect at the receptor in that tissue. But when it goes to a different tissue, it could have an antagonist effect there. Every cell can modify their receptor a little bit differently. And so ovarian cells have the estrogen receptor, but they modify it a little. Breast cells have the same estrogen receptor, modify it a little. If estrogen binds, it's generally going to activate both of them. It doesn't care. An estrogen antagonist binds, it's going to inhibit both of them. It doesn't care. So almost every single drug that we put in is either an agonist at all of them or an antagonist at all of them. But sometimes we want to activate cells in the vaginal tissue, but not in the breast tissue. Or we want to be able to finesse which tissues we want to activate without activating all of them. And this is just another level of letting us be really specific in our drug targets. In that if we have these selective receptor modulators, we can go, this drug is going to be an agonist at estrogen receptors here, but not here.